I'm going to talk about anxiety disorders and what's kind of happened to that category. When you think back to the DSM-2, that was very psychoanalytically based, pretty much all the neurotic disorders were related to anxiety. And then around the time of the DSM-3, suddenly we had this concept of an anxiety disorder, which was a set of symptoms that were not necessarily due to neuroses, and they no longer were connected with all the other neurotic disorders. I find that so interesting that suddenly we had specialty clinics to treat anxiety disorders, which was something that would have been considered ubiquitous to all the neurotic disorders prior to that. So now what we're seeing is yet another step in that. Now we're seeing the dismantling of the entire anxiety disorders structure into 3 sections, and I'm going to move ahead and then move back here. No, I think we've lost a slide. No, here it is. Okay. So the anxiety disorders category is now being split into 3 chapters. One is very much like the anxiety disorders you're used to, except it will not have a few things. It will no longer have OCD, which has now been regrouped, and it will no longer have PTSD, which has also been regrouped into a new structure. So I'm then now going to go through each of those and talk about some of the criteria that are going to change within those. So some comments about anxiety disorders. So you do notice that PTSD is no longer there. Those of you who work with kids will notice that separation anxiety disorder is now there. That's something that's an overall theme of the DSM-5, that disorders that would have originally been in that section, like disorders first seen in infancy or childhood or adolescence, are now associated with their adult subtypes. And this is so I think it's because it's believed often that the childhood subtype may be a prodrome to the adult subtype. So just a few comments on here. Panic disorder and agoraphobia are now separate diagnoses. I know that in the DSM we had, I think, agoraphobia with panic, and then in DSM-4 we had panic with agoraphobia. We're no longer doing that, so we're now having 2 separate diagnoses. If someone has both of those, they would presumably get a subtype that would involve both diagnoses. For agoraphobia and panic disorder and social anxiety disorder, here's another theme, this issue of is it syntonic or dystonic. For those 3 disorders, for it to get that disorder, it used to be required that it be dystonic. And now it's felt that actually a lot of people, if you've worked with people with anxiety disorders, and I have, in the thick of an anxiety state, whether it's syntonic or dystonic is a moot point. In other words, many people who have a very, very severe phobia may really feel that if they get near that spider, they're going to get stung and die. And so the specifier, the assumption that it has to be dystonic is being removed. There's also an extension of required duration of all ages for 6 months. So you have to be afraid of whatever you're afraid of for a while. So there's this uncoupling of the panic disorder and agoraphobia diagnoses. Social phobia is now called social anxiety disorder. And for those of you who've worked with people with a diagnosis of social anxiety disorder, you may have realized that there seems to be an uncomfortable kind of living together of 2 aspects of social anxiety disorder. To me, one sort, almost, it's very global. It's somebody who is just afraid of people in all circumstances. Often there's some paranoia in the background, or vigilance. People are looking at me, and there's difficulty in engaging in all kinds of relationships as a result of that. And then you have this fairly narrow type of social anxiety that's often referred to as performance anxiety. And I think we now realize that those 2 disorders have very different outcome and could be treated differently. So there's now a performance-only specifier for the social anxiety disorder area. And then we still have GAD. What is supposed to now unify all of these is a traditional, idea of anxiety, that it is a state associated with preparation for future disaster or negative events or negative scrutiny. And physiologically, that's seen to be related to the amygdala, which is the part of the limbic system that has conditioned emotional responses, and the hippocampus, which also involves conditioned learning, conditioned emotional learning. Okay, now when I worked in my anxiety disorder clinic in the 1980s, obsessive compulsive disorder was part of what we did. So if you work with people with panic or agoraphobia, you were also probably doing behavioral exposure for people with OCD. So for me, that's part of the same group, but actually it's now being pulled out. And it's being pulled out for a number of reasons. The working group in 2009 felt that this whole group of disorders maybe defined disorders that were related physiologically as well as genetically. So body dysmorphic disorder, OCPD, Tourette's syndrome, and trichotillomania are similar to OCD in terms of phenomenology and comorbidity and the familial and genetic features. And there also, in other words, there's a very high prevalence of OCD symptoms and OCD in families of people who have Tourette's, and high rates of tics in members of family who have OCD. So generally the feeling is that these work together as a family much better than where these other disorders used to be, which is in impulse control disorders, like the hair pulling and trichotillomania. I'm sorry, that is trichotillomania, and skin picking disorder. So, however, it's also true that there's a very high level of anxiety disorders among relatives of people with OCD. So we were not crazy to have included those in the same category for so many years. So I think this is going to be an interesting and uneasy division, where I think many people will continue to think of OCD as essentially an anxiety disorder, and others will now think of it more of an impulse disorder related to the circuitry in the brain that involves urges and movements and rituals to deal with those urges. In particular, the OCD spectrum, if I could call it that, relates more to the basal ganglia and its connections to the frontal lobe, which is also called corticostriatal circuits. And also thought to be more related to the neurotransmitters dopamine and glutamate. So we are now seeing this as a separate group, and with the emphasis being on repetitive thoughts, urges for repetitive movements. Now, any of you if you've ever done behavioral intervention for people with OCD, you know that there's tremendous anxiety, panic, and tremendous certainty that, if I don't count to 5 this way, my father will die. If I don't, wash my hands in this way, I will contaminate the whole family. So we will continue to be very aware of anxiety as a central feature of OCD. Hoarding disorder, any of you who have been watching the television shows, there are now all these hoarding television shows. I think it's, we love watching people acquire things on the game shows, and then I guess we like watching them get rid of them on the hoarding therapy shows these days. But this is going to be a new diagnosis. It used to be thought of as one of the descriptive parts of OCPD, of OC personality disorder, but many clinicians have treated it as part of the OCD disorder. In any case, now it's going to be a separate disorder, and it describes people who can't discard items, either because of indecision or because they just can't organize or because they feel emotionally attached to them. And it'd just be interesting to see if this is diagnosed to a large degree in the future. It appears that there are 2 subtypes of hoarding disorder that are kind of emerging, and one is thought to be more associated with organic brain disease. So it might be people with dementia, developmental delay, or organic brain disorders. And that sort of hoarding it tends to be less specific. So just people who are, just holding on to everything in their house. They have a lot of junk. They have a lot of garbage. They may have old food. They just live in squalor. They hold on to everything. And that subgroup is believed to often be willing to have other people do the cleaning for them. The other, and I think that you often see them on the television shows, maybe because it just looks more exciting. The other group are people who have variable insight, and they're very selective about what they hoard. They will not let other people clean their house, and this seems to be more familial. So it'd just be interesting to see what happens now that we have an official diagnosis for that. A number of other comments. There's now, remember we talked about insight specifiers. For OCD and body dysmorphic disorder, there's also going to be a poor insight specifier because that notes that there tends to be poorer outcome. And the other thing is that often when people have OCD with very poor insight, others think that that maybe it almost verges on delusion. And by having a poor insight specifier within OCD, you may potentially keep that group of people out of the delusional disorders category. And finally, there's going to be an OCD diagnosis related to medications or medical conditions. There are a number of medical conditions like Huntington's chorea that at some point present with symptoms that look like OCD.